Our next speaker is an assistant professor at University of Texas Biomedical School, manager of the Pelvic Health Program UT Health Austin, sexuality counselor, and is the only Black physiotherapist with this designation. She also serves in the role of adjunct faculty for sexual health certification program at University of Michigan School of Social Work and a founder of UC Logic. Please welcome Dr. Uchenna Ossai.
Hello, everyone. I'm so excited to be here. I'm actually a pelvic health physio, and I focus on sexual dysfunction of persons of all genders. And so one thing that we often don't talk about in the pelvic health world, or really the healthcare world, is the intersections of the biopsychosocial model when it comes to our overall health. So next slide. So what is our health? How do we define our health? And next slide. When I was in graduate school, when I was getting my doctorate in physical therapy, my perspective of health was very singular. I thought, okay, well, I'm a Black woman in America. I'm a first-year grad student. My individual choices and genetics dictated my health status. Next slide. And so this is a very much traditional view that I think all of us worldwide have the concept of our health. Like, we just need to pull ourselves up from the bootstraps. Our health is solely determined by our individual behaviors. I need to eat better. I need to do more me time, meditate and relax. Does that sound familiar to anyone? And then when we're thinking, next slide, right? And so then when you're thinking about, your traditional view of sexual health. So my traditional view of sexual health was, let me just prevent an unplanned pregnancy. Let me prevent STIs, birth control options, being able to talk to my friends about sex freely. That was how I viewed as sexual health. So there was no discussion of pleasure. There was no discussion of the intersections that influence my life and my health and well-being, as well as what influences the health and well-being of so many people. Next slide. So when I was in Houston, Texas, I was at Houston Methodist Hospital. I was assistant professor there for a very long time. And I would query my patients and I would ask them, I said, why do you care about sex? Why do you care about sex? And this is what some of them said. I've never thought about sex that way. It feels amazing and I like it. I want to have kids and this is the cheapest way to do it. It regulates my stress. It's a barometer for my relationship. It gives me the upper hand. I need to keep my marriage. It keeps my partner in check, for real though. So lots of different themes and lots of different motivations and why people engage in sexual activity. But for many of these people, they were not given the permission to look at it outside of their own lens, right? So many people say it regulates my stress, but they didn't dare think it was a fabulous or amazing or a way to have children or a way that indicates what's going on in their relationship, or not just with their partner, but with themselves. Next slide. And so this is all back to that biomedical model that I think really kind of just needs to be put in a box and on a boat in the ocean to go away, because this really talks about, all illness has an underlying cause. The disease is there's always a single cause, right? There's no intersecting factors, but that's just no longer how we should be looking at our health and our sexual health. Next slide. So when we're talking about pelvic floor dysfunction, I think it's important to discuss this because this occurs worldwide in about 1 in 4 women and vagina owners, and about 1 in 8 in men and penis owners. And when you think about it, it's an umbrella term. It's used to describe anything going on below the pelvis, and it can be influenced by genetics, surgeries, medications, psychological issues, as well as musculoskeletal dysfunction. Next slide. And so you can categorize this into pain or support disorders. And this is a long list, and I'm not going to go through it in too much detail, but when you look at it, vulvodynia, vaginismus, which is, where the outer third layer of the pelvic floor muscles contract and you're unable to have any type of penetration, whether that's a finger, a tampon, penis, toy, dyspareunia, pain with sex, prostatitis, or male pelvic pain, right? Rectal pain, pain with defecation, even C-section episiotomy scars. Those can lead to vulvar and vaginal pain, and as well as sexual dysfunction. Next slide. Not to mention urinary incontinence, right? So these are the support and coordination conditions, right? They lead to lots and lots of sexual dysfunctions. Can you imagine, walking down the street and then coughing and then peeing yourself? Some of you have that experience. Some of you have not had that experience or will eventually have that experience, but it doesn't make you feel sexy, right? It doesn't make you feel like you want to engage in sex, or you may be self-conscious and you're afraid that you're going to urinate on your partner unintended. Like if that's the goal, fabulous. But if that's not the goal, that can be really, really difficult. Next slide. And so why I'm bringing this up is that basically pelvic floor dysfunction and sexual dysfunction go hand in hand, right? So if you're thinking about someone who has chronic constipation, so if you're straining, or you have a bowel movement every 5 to 6 days, you're actually literally full of poop. So it's not like you're going to really be wanting to you're not going to be feeling like your sexy optimal swagger. You're not really wanting to engage with your partner. But oftentimes when people have constipation, they're going to their healthcare provider and they're saying, I want to solve my constipation, but they have the sexual dysfunction that they don't view as important as a constipation, right? They're saying, I don't have orgasms, or I have premature ejaculation, or I have pain with intercourse. Next slide. So this is where we want to talk about intersectionality. This is where I think that this is where healthcare should be looking at in terms of shared decision-making with patients, our clients, all together. How do we look at health? Next slide. So I always tell people that intersectionality challenges the status quo. It challenges the concept of blaming the patient, right? That pulling yourself from the bootstrap, that's an incomplete way to look at your health, right? You have to look at the intersecting systems of power, right? And how that can result in a lived advantage or disadvantages that can marginalize certain populations, particularly when it comes to people of color. And we'll talk about that in a few moments, right? But it's an analytical tool. It's an analytical tool to look at the complexity of the world around someone. So instead of just looking at, oh, I have sexual dysfunction and there's something wrong with me. No, we have to look at it at a more complete circle. Next slide. So that's where the biopsychosocial model comes in. So all of us, like if you kind of cover the last 3 circles and just look at the biological circle, that's where a lot of us focus our energy on. We want to get rid of those things. What's going on with my hormones? What's going on with my scarring? But we fail to kind of intersect all of these pieces, the psychological components, the sociocultural and the interpersonal components. When we're looking at emotional distress, trauma, microaggressions, body image, heterosexism, transphobia, misogyny, gender norms, that's a huge one, right? And of course, interpersonal issues, relationship issues, fear of movement, the expectation of pain. These are things that we have to really understand when we're talking about our health. When we're talking about our sexual health, this is essential. I feel that this should be in every kindergarten class in the world, because this is how we need to start looking at our health. This is how we need to start understanding how to engage with ourselves sexually, because this is the root. This is the root of it. Next slide. So obviously, I've said it many times already, sex is multifaceted, right? Everyone has their own footprint. I always say this to my patients and clients, right? It's not genital dependent and exists on a spectrum, and everything influences it. Everything from religion, hormones, social media, what we put into our brains. Next slide. Pregnancy, postpartum, what's going on with our policies and our government, whether that's local or more at the federal stage, our gender identity, race, and ethnicity. Right? Next slide. So people who have any type of sexual dysfunction do not view themselves as healthy as someone who does not have sexual dysfunction. And so we have to recognize that this is an indicator of health. Next slide. So why do health disparities, and when I say health disparities, I'm talking about sexual dysfunction, I'm talking about sexual being and exploring, why do these persist, even though we control for individual behaviors? And so I'm going to get into a topic that I think is relevant in what's going on in the world right now in terms of, anti-Black racism and what does that mean not just for Black lives, but for really all of our lives. Next slide. So when we think of the concept of racism, right? So that's a system of oppression that's assigning value on someone based on their race, right? And it has to occur in a racially conscious society. So some people have inherited advantage, some people have inherited disadvantages, but one thing we need to understand is that it minimizes the strength of society as a whole. Next slide. So when we're thinking about racism, we have to think of it as in three tiers. You have the institutionalized racism, right, which is that historical initial assault, right, of colonialism, slavery, worldwide, right, in action in the face of need. So policies that explicitly ignore the history of racism and how that impacts one's opportunities, because that's the thing that racism does. It structures opportunities and it dismantles one's ability to access healthcare, to access information. And that is really important because when you think about the interaction between particularly minority populations, ethnic and racial minority populations, sexual minority, gender minority populations, when you add on the components of race, when you add on the components of ability or gender, sexuality, those add on top of each other. But when you add race on top of it, it compounds the disparity because of implicit bias as well as explicit bias. Next slide. So then this is the type of racism that we're all used to seeing, right? It's how we treat one another, right? Experiencing work microaggressions or macroaggressions. You can see, someone having, caught any type of verbal assault that someone experiences or physical assault from police and authorities. This maintains those structural barriers, right? Because a lot of times, most of what the discussions are happening around right now is really not necessarily, yes, the overt racism, but then of course those that occur when we don't need to, right? That requires a lot of internal adjustment with the person of color, the Black person, the person of color, they have to adjust, right? And they have to not only be their true self, they have to kind of protect themselves at the same time. And that stress is real. Next slide. So when we're thinking about, this is the last layer that a lot of us forget about, is that internalized racism. And this is where the stereotypes come in, right? This is when those stereotypes about certain ethnic and racial minorities, such as like a Latina woman being like hot and fiery, or a Black man being brute and having a big dick and just being, or a Black woman being a hoe or angry. These are when those can be internalized and where that energy is really put into fighting those stereotypes that you're not going to see in other cultures. Next slide. So when we're talking about minority stress, this is a model from Dr. Meyer from Stanford that he developed many, many years ago, but it still holds true today. We're thinking about what has to happen in order for someone to really realize their true self, and not just their identity, but their sexual self, right? So if you have environmental circumstances and general stressors, you internalize, in this case, their homophobia, but you can apply this to sexism, you can apply this to racism, you can apply this to any of the isms that we experience on our day-to-day life, right? There's a lot of coping. There's a lot of, I'm going to hide this, or I'm going to expose this. There's a lot of adjusting and kind of finding a path to circumvent the experience to minimize their exposure, because that can be really dangerous, particularly if you're talking about individuals in an academic or professional environment. Next slide. And so again, this kind of explains that a little bit further, is that individuals from disadvantaged social positions experience chronic and unique stressors related to these positions are founded in oppressive structures, right? They expect rejection, they hide and conceal, they internalize that experience. And then of course, their coping processes don't always help. They're not always helpful in terms of their physical well-being as well as their emotional well-being. Next slide. And so like I said before, we have to start thinking about our sexuality, our health, in terms of how do these systems play a part. If I can't express myself fully, right? How, the intervention isn't necessarily going to be Viagra, right? The intervention isn't necessarily going to be topical lidocaine cream. It might be acknowledging the intersections that that your patient, your client, you yourself, your friend, your family member is experiencing. And understanding that color is how they view themselves and how they express themselves. Next slide. So this is one of my favorite slides, because when you think about the impact of chronic stigma, this is what I see a lot, right? So when you think about racial stigma on top of sexual stigma on top of gender stigma, that equates to increased health disparities, right? And that consistent is key, the consistent exposure to stressors. Whether the stressors are intended or intended, results in a poorer mental health and physical health. Next slide. As well as when you think about what does that mean? Well, we're thinking about musculoskeletal dysfunction, bowel and bladder dysfunction, sexual dysfunction, decreased pain management, right? So a key piece here, especially when you're thinking about the opioid crisis that's kind of expanding worldwide, you're having disparities in chronic pain that are associated with minority stress, right? So you have that stress, but then you might have the implicit bias of the provider that may not take their pain as seriously, or they might have preconceived notions and saying, because we still have med students that believe that Black people can handle pain better than white people. And that's just categorically untrue. Next slide. So how do we bridge the gap? How do we connect this into, sexual health and wellness? Next slide. Well, we have to educate ourselves that health is beyond individual choice. It's individual choice, but there's so many other components that influence our health. And we have to think of it as equity. We need to build equity, structural, interpersonal, and individual. That's how we can decrease health disparities. That's how we can elevate our collective sexy swagger in health. Next slide. So when we're thinking about pelvic floor and sexual dysfunction, a multidisciplinary approach is the most effective strategy. And this is where I believe that when we're thinking about extended reality and VR environments, this is where we can say this needs to be part of that team. We can create systems and apps and interventions that allow people to understand these intersections and how they play a role in how they view themselves and how they engage with others and how they engage sexually and with their own sexuality, right? Because when we think multidisciplinary approach, we're thinking, oh, they need a yoga instructor, they need a PT, they need a doctor, they need a nurse, but we also need technology. We need to move past this so we can actually deep dive into what are these real components that we're addressing, because it's more than just medication, prescription, and surgery intervention. Next slide. So this is just an example of one of my patients. He was a 35-year-old male with rectal pain and painful ejaculation. And when he came in to see me, he had Crohn's disease, he had interstitial cystitis and painful bladder syndrome, which is basically every time his bladder fills, it feels like his bladder's on fire. It's like he's peeing fire. It's awful. He has chronic back pain and acute pelvic pain. And he thought he just needed to have surgery, right? And he thought that, he didn't believe in physiotherapy. He's like, I don't know about this. My doctor's forcing me to come see you. And so I said, okay, that's cool. But I talked to him about the biopsychosocial model. I educated him on that. And then I did a blank sheet and I had him fill this out. And this is what he produced. Isn't this fascinating? He was like, well, psychologically, I have a lot of anger. I have a lot of increased anxiety, fluctuating mood, and I have PTSD because he did 3 tours abroad in Afghanistan. Right? He grew up Mormon. He was homosexual. He was not comfortable being gay. He's never talked to anybody about that. He has anti-gay family values. He hasn't spoken to his parents since he was 18. He's white, military, and masculine identifying. Interpersonally, he hates small talk. He said he had low tolerance for dating, no bandwidth due to his chronic pain. He was short-tempered at work. He avoids people because he's not in the mood, and he said his boss sucks, which I'm sure we can all relate to at some point. But it was really empowering for him to look at this and say, oh, okay, so it's not just because I personally suck that I'm having all of these issues, because he also had really low libido and erectile dysfunction. And when we finally broke this down, I said, you know what, we need to get you linked up with a mental health provider. But we also need to get you We need to get you understanding all of these issues that are at play and that influence how you express sexually. Next slide. So what's missing? So this is where I think we can all be creative in terms of designing environments like virtual reality environments that help us close these gaps, because there aren't any clear models for sex and pelvic health education for adults or for sexual communication, right? A lot of times marginalized communities aren't reflected in these efforts, and there aren't many medical healthcare professionals in the social media landscape really explicitly talking about that. That's growing and it's getting a lot better, but I think it should be really flooded with this message of understanding it from a biopsychosocial framework. And I know from a personal professional issue, sexual health was not core training for pelvic health physiotherapists. I know that in America, it's starting to be the case for medical providers or for medical doctors, but not necessarily for a lot of other healthcare providers. And not many physical therapists in my field worldwide were talking about sex. Next slide. And so what we found is that social media for health communication is huge. This is a really big opportunity for a lot of people to understand that, but then also bring that into that virtual reality space. And I think also identifying what the gaps are is important, and helping our patients be informed about teasing out, what is going to be helpful for you, because this can influence health policy. This can influence public health surveillance, and as well as peer and social and emotional support, which is huge. Next slide. Next slide, sorry. This is basically a summary of what I just said. So one of the things I like to think about is when we're thinking about what can be really helpful is user-generated content, right? Immediately recycling the information that we have back into the community, especially when it comes to research. We see this a lot in terms of trust within minority communities in particular, normalizing sex and acknowledging the historical stereotypes that have a play in how people engage in sex, because there's a lot of respectability politics, particularly when it comes to Black and Indigenous people of color. Creating health models of discourse, of discussion, being inclusive, collaborating with brands that target vulnerable populations in a positive way and engage them so that they can bring it back to their community, and collaboration with other healthcare and wellness professionals. Next slide. So now, what do I view health to be? So what is health, right? So health perspective, sorry, that's the typo, 2020. Now, as 10 years in, I'm a cisgender female, heterosexual Black. I'm first generation American. My parents are from Nigeria. I live in Texas, which is a very, very conservative state. I'm one of three Black women in positions of leadership and clinical management in my institution, which is a major university in Texas. And now I understand that my lived experience impacts my lens as a patient as well as a healthcare provider. Next slide. So thank you. And I appreciate your time. I hope I didn't go over.